Today we will be taking up pre-malignant lesions of the vulva and vagina. Now, the vulva and vagina are one of the openings of the female genital tract, and here they are the main anatomy is the mons veneris along with the clitoris, the outer labia and inner labia majora, and the opening of the urethra, the hymen, and the opening of the vagina along with the surrounding. Here the skin is mainly squamous epithelium. Since this area has lot of hair and glands around it, the most of the pathologies, they involve the squamous epithelium and the hair follicles. The common pre-malignant lesions involve the atypical melanocytic nevi of the genital tract type, the condylomas, the differentiated vulvar intraepithelial neoplasm, dysplastic nevi, the vulvar intraepithelial neoplasias, and the aggressive neoplasms involve the angiomyxomas, the Bartholin gland carcinoma, the baseloid carcinomas, the Bowen's disease, epithelioid sarcomas, and the malignant neoplasms also involve the leiomyosarcomas, melanomas, Merkel cell carcinomas, metastasis from the surrounding areas, Paget's disease, pigment lesions, squamous cell carcinoma, and warty carcinomas. First, we'll take the atypical melanocytic nevi. This is usually found around the vulva, perineum, mons pubis, and axilla, and usually it occurs in the young age, around the age of 25 years, and microscopically it shows a non-specific stromal pattern. The condyloma is a sexually transmitted venereal disease caused by human papilloma virus, usually type 6. The sites usually involved are the vulva, vagina, perianal, the perineal regions, and the condyloma is acuminata is a better known form. Grossly, one or several elevated masses are seen. Typical picture of the condylomas on cut section, the same on cut section. Microscopically, it shows a complex papillary arrangement of well differentiated squamous cells with intact basement membrane, hyperkeratosis, orderly maturation, and well vascularized tissue stalk containing mononuclear infiltrates. On cut section, you can see this is the stalk, and these are the squamous epithelial cells. The flat condyloma involves the collocytosis of the Malpighian epithelium. The flat condylomas are more common, and they involve collocytosis of the epithelium and the basal epithelium, along with the lymphocytic infiltration of the stroma. And collocytosis involves the perinuclear cytoplasmic clearing along with crinkling of the nuclear membrane. So this is the collocytosis, and here there is parakeratosis. These are the features of a flat condyloma. There is a term vulvar intraepithelial neoplasia, just like cervical intraepithelial neoplasia. It involves the variable hyperplasia along with keratinization and marked atypia of the basal layer of the squamous epithelium with normal epithelial maturation and differentiation in the superficial layers. There is variable human papilloma virus. Quite often on the labia majora, then on the labia minora, we see dysplastic nevi. They are large and mostly acquired nevi, more than 5 mm in size, and they number in hundreds. They are basically flat macules and darker rays centrally with flat periphery. Microscopically, the stroma has a concentric eosinophilic fibroplasia or lamellar fibroplasia. The vulvar interepithelial neoplasia, also sometimes known as the Bowen's disease, is a pre-malignant condition and accounts for almost 3% of the genital cancers. Over the last 5 to 10 years, the incidence has markedly increased with more women of the 20 to 35 years. They are getting involved, and grossly we find the elevated plaque-like lesions with red velvety appearance. Now, this is a picture of the vulvar intraepithelial neoplasia. On naked eye, it's a reddish plaque-like area, and quite often with the acetic acid test, it comes positive. There is hyperkeratosis and parakeratosis, acanthosis at different levels, and multinucleated disc keratotic cells can be seen. There is abnormal mitotic figures, and there is strong association with human papilloma virus 16. Now, this is the picture of vulvar intraepithelial neoplasia. You can see the whole epithelial layer of the vulva is involved. However, the basement membrane has not been penetrated, and we can see the hyperkeratosis, parakeratosis, and some acanthosis. Bovinoid papillosis is another entity which involves the multiple pigmented papules in the vulva, and clinically we find that they resemble condylomas, but they show cytologic atypia which is generally absent in the condylomas. The vulvar intraepithelial neoplasia, it has got a classic type and there are variants. The classic type is basically the carcinoma in situ, which does not penetrate the basement membrane, and the Bowen's disease, or also known as Bovinoid polyposis. We also get the basaloid and Vati carcinoma. The classic variant develops from precancerous in situ lesions with the nuclear atypia and lack of maturation of squamous cells. There is increased mitosis, and the variant includes maturation, hyperplasia, keratinization, and parabasal atypia as well. The risk factors, it involves the young at the first intercourse, and multiple sexual partners is another one. The male partner who has these multiple sexual partners. The classic vulvar intraepithelial neoplasia is positive for human papilloma virus 16, 18, and 31, and the risk of progression depends upon the age and immunosuppression. The morphologically, there is discrete white hyperkeratotic patches with flesh-colored or pigmented, slightly raised lesions. Coexisting carcinoma or exophytic or indurated are seen frequently with ulceration. The malignant lesions of the vulva, most common is the squamous cell carcinoma, comprising of almost more than 80% of cases, followed by the Paget's disease, hidradenoma papilliferum, syringoma, basal cell carcinoma, Merkel cell carcinoma, sweat gland carcinoma, sebaceous gland carcinomas, malignant melanomas, and aggressive angiomyxomas, along with Bovinoid disease and epithelioid sarcomas. Firstly, the invasive squamous cell carcinomas, it is of course commonest, and more than 95, sorry, not 80, but more than 95% of the malignant tumors are invasive squamous cell carcinomas. and their mean age is the older age group, the 60 to 75 years age group. The risk factors are the multiple sexual partners, smoking, immunodeficiency, and genital granulomatous diseases. The types are basically those occurring in the older woman or human papilloma virus and negative, and those occurring in the younger woman, that is human papilloma virus positive. The common sites are the labia majora, labia minora, and the clitoris. Basically, it appears on the side or on the clitoris, labia majora, labia minora. Microscopically, they are well differentiated and located in the clitoris. They are more anaplastic. Like typical keratinized variants are seen with the epithelial pearls, or there are variants which have the keratin deposition is less and we get lot of cells with atypical features. The prognosis of vulvar intraepithelial neoplasia depends on the tumor diameter, the depth of invasion, and the lymph node status. And quite often, when the depth of penetration is less than 5 millimeters, the incidence of lymph node metastasis is also less. Now, this is the vulvar intraepithelial neoplasia, and you can see in the when it does not penetrate the basement membrane, it is just in the superficial layers, and sometimes it does. When the prognosis is bad, then it spreads. Verrucous carcinoma, or the superficial one, it is the distinct type of squamous cell carcinoma. It may grow to huge dimensions superficially and is typically exophytic appearance and infiltrates locally. The other variant is the warty carcinoma, or lymphoepithelioma-like carcinoma. This is the variant which is quite superficial and spreads locally. The Paget's disease is a malignant tumor of the vulva, and it is viewed either as a sweat gland carcinoma arising from primarily from the intraepidermal portion of the gland, or as a carcinoma of multipotential cells located along the epidermal basal layer that differentiate along the glandular lines. Clinically, it shows crust and elevated scaling erythematous rash in the labia majora, minora, and perineal skin. It is something just like the Paget's disease in other areas of the body, like breast or the penile areas, and there is a reddish rash, and this rash, the microscopically we find the pale tumor cells which form solid nests, glandular spaces, or continuous along the epidermal basement membrane. It stains positive with the Mayer's mucicarmine and the aldehyde fuchsin stain. These are the Paget cells which can be seen in the superficial epidermal layer, just like the Paget's disease in the other parts of the body. Immunohistochemically, the mucins are positive for MUC1 or MUC5AC, S100, CK7, and CK20, and it is reactive for HMG45, and it is not associated with underlying invasive carcinoma. If we do not find any invasive component, then the prognosis of this is good, and the metastasis does not occur. Hydradenoma papilliferum. This presents as a small, well circumscribed nodule covered by the skin, and microscopically complex papillary gland pattern can be seen, along with stratification, pleomorphism, and myoepithelial layers. They can also be seen. See, this is the hydradenoma papilliferum. We can see a frond-like appearance. All papillae, like a complex papillae, are formed, and there is a stratification. Syringoma of the vulva. This involves the tadpole-shaped structures in the dermis, and another entity is the basal cell carcinoma of the vulva, involving the nodular mass in the labia majora of the elderly patients, and it may even ulcerate. The types are solid, keratotic, and adenoid type, and histologically it arises from the epidermis or follicular epithelium. They do not occur on the mucosal surfaces, and microscopically the nests of the uniform atypical basaloid cells are within the dermis. This is the typical picture in the dermis. The nests can be seen, or basal cell carcinoma of the vulva. There is a peripheral palisading appearance just like in any other variant. Microscopically, we find the relative uniform population of small ovoid cells with high nuclear cytoplasmic ratio, peripheral palisading, and deep basophilic staining pattern. The human papilloma virus is positive. This is the basaloid carcinoma with peripheral palisading arrangement in the vulva. Merkel cell carcinoma is another disease which is very aggressive and associated with Bowen's disease. Grossly, it involves the slightly elevated plaques like red velvety appearance centered on the labia majora, perineum, and anus, and microscopically the disorganization of the epithelium, hyperkeratosis, parakeratosis, and acanthosis can be seen with intracellular bridges. It stains with the P50 positive with P53, and human papilloma virus 16 is positive on molecular staining. The melanomas are also quite, I have in my life seen 2 or 3 cases of malignant melanomas of the vagina. Even on cytology, I have seen 1 case. The usual age is around 50 years, and grossly we find large polyphoid, deeply pigmented ulcerated lesions, a large growth, darkly pigmented, can be seen, and microscopically the spindle cells are seen growing in fascicles, superficially spreading type. It shows intraepidermal growth of pagetoid cells with angiogenesis. This is the melanotic cells, and in another variant, I think we should see the cells with the which stain positive with immunoperoxidase staining. The aggressive angiomyxomas are slow-growing perineal lesions that arise from the vulvar mass or polypoid mass, and the age is around in the young adults, and there is a gelatinous ill-defined mass. The aggressive angiomyxoma is involves the spindles and stellate cells in hypocellular myxomatous stroma, and there is no atypia, no mitosis, and the thick-walled vessels with dilated lumina can be seen, and hyaline thickening of adventitia is seen with the extravasation of red blood cells. There is positive stain for actin and negative staining for S100, factor 8, CEA, and keratin. There is a carcinoma of the Bartholin glands, and it has got various forms in the form of squamous cell carcinoma, adenocarcinoma, transitional cell carcinoma, and small glands, and this is the carcinoma of the in the Bartholin's gland. The other tumor-like conditions are the fibroepithelial polyp, which is basically a superficially located lesion composed of loose myxoid stroma covered by normal squamous epithelium, hypercellularity, and stellate lesions. Frequently, multinucleate cells may be present. This is the fibroepithelial polyps. A number of tumor-like conditions which we will not take up in detail, but they are also there, like leiomyomas, leiomyosarcomas, hemangiomas, glomangiomas, glomus tumor, angiosarcoma, rhabdomyosarcoma, benign lymphoid hyperplasias, malignant lymphomas, and even sarcomas, they are there. Now coming to the vagina. Vagina is basically a tubular structure derived from the Mullerian ducts that extend from the vestibule of the vulva to the uterus, and histologically it comprises of mucosa, muscularis mucosa, and adventitia. The pre-malignant lesions which are involved are the intramural papilloma, which has a branching configuration and a lining of single layer of cuboidal cells, and they have it may be present as polyps or intramurally, and the squamous cell papilloma is seen in the adult vagina caused by human papilloma virus. The pre-malignant lesions, they involve the tubulovillous adenoma mixed benign mixed tumors, and they are located in or near the hymenal ring composed of the small stromal type cells and along intermixed with the mature squamous cells and glands lined by the mucinous epithelium. This is the typical mucinous epithelium. Tubulovillous adenoma involves a large number of glands with mucin producing cells, and which are positive for CD4, BCL2, and CD99. These stains are in our setup. Generally, these positivities are there, but mainly with H&E itself, we are able to find them. The vaginal intraepithelial neoplasia. This is traditionally known as the in situ squamous cell carcinoma. It is multifocal and arises from the squamous epithelium in contrast to the squamous cervical cases, which originates from the metaplastic squamous epithelium. It is associated with neoplasm of lower genital tract. The upper third of the vagina is the commonest site. The treatment is local excision, partial or total vaginectomy, or laser therapy. See, this is the vaginal intraepithelial neoplasia. It has not penetrated the basement membrane, and we can find lot of atypical cells with hyperchromatism and mitotic figures. The other vaginal neoplasms are epithelial neoplasms, the mesenchymal tumors, mixed epithelial tumors, melanocytic tumors, and miscellaneous tumors. The epithelial neoplasms involve the squamous tumors and precursors, the glandular lesions, and other epithelial tumors. The squamous tumors involve the squamous cell carcinoma, not otherwise specified, the squamous intraepithelial neoplasia, the benign squamous lesions like condylarthrioma acuminatum, and the squamous papilloma fibroepithelial polyps. The glandular lesions involve the adenocarcinomas not otherwise specified, clear cell adenocarcinomas, endometrioid and adenocarcinomas, mucinous adenocarcinomas, mesonephric adenocarcinomas, Mullerian papillomas, and adenomas which are not otherwise specified. The other epithelial tumors are adenosquamous carcinoma, adenoid cystic carcinoma, the adenoid basal carcinoma, carcinoid, small cell carcinoma, undifferentiated carcinoma, the mesenchymal tumors, which are we will not be taking them in detail today. The sarcoma, botryoids, leiomyosarcoma, endometrioid stromal sarcoma, undifferentiated vaginal sarcomas, the alveolar soft part sarcomas, leiomyomas, and deep angiomyxomas and post-operative spindle nodules. The mixed epithelial and mesenchymal tumors involve carcinomosarcoma, that is mixed Mullerian, mixed tumors, metaplastic carcinomas, adenocarcinomas, the mixed tumors involving the synovial sarcomas, and mixed benign mixed tumors. The melanocytic tumors involve the malignant melanomas, the blue nevi, and the melanocytic nevus. The miscellaneous tumors involve the tumor of the germ cell, yolk cell sac tumors, dermoid cysts, and other peripheral primitive neuroectodermal tumors, Ewing sarcoma, adenomatoid tumors, malignant lymphomas, granulocytic sarcomas, and the invasive squamous cell carcinomas, which are less common in the vagina and largely are a disease of the elderly. They may be human papilloma virus positive here, unlike the vulva, and the grossly they are nodular or ulcerative, and upper third and anterior or lateral walls are common sites of origin. The red discoloration, more than 95% of the vaginal carcinomas are conventional squamous cell carcinomas with varying degrees of differentiation, just like any other squamous cell carcinoma anywhere in the body. And treatment is local XE and external and intracavity radiation, radical surgery for cases located in the upper vaginal third and posterior wall, and 5-year survival rate is between 40 to 50%. This is the vaginal intraepithelial lesions or squamous cell carcinoma with penetration deep in the underlying mucus, the muscular layers. The clear cell carcinoma, which is also known as the adenocarcinoma, occurs in the anterior or lateral wall in the upper vagina in the uterine cervix of children, adolescents, and young adults. And rarely they occur before the age of 12 or after the age of 30, and grossly involve most of the vagina, and the polypoid and nodular variants are there, which along with the flat or ulcerated with granular surface. Microscopically, we find the tubules and cysts lined by clear cells alternating with the solid areas with papillary formations. Mitotic figures are usually scanty, and tumor cells have abundant clear cytoplasm, and hobnail shaped cells can be seen. This is the hobnail appearance. Hobnail, just like we have hobnail like appearance in the this area stellar reaction, large growth coming out just like the horseshoe or the nail in the this is the hobnail like appearance. Another one with mucin with clear cells, and immunohistochemically it is positive for CK7, CAM 5.2, CEA, CD15, vimentin, BCL2, CA125, ER and HER2 new negative for CK20 and PR. The spindle cell carcinoma, it microscopically presents with the elongated cells with mesenchymal-like appearance surrounding a well-defined nest having a clear-cut epithelial appearance. The other carcinoma types are mucinous adenocarcinoma or mesonephroid adenocarcinoma, endometrioid adenocarcinoma, the transitional cell carcinomas, the basaloid carcinomas. The mesenchymal tumors are the fibroepithelial polyps seen in the adult woman during pregnancy or in neonates, and the hormone-induced localized hyperplasia of the loose subepithelial connective tissue zones. And grossly, we see mushroom-like appearance in the mesenchymal tumors. Microscopically, there is a central fibrovascular core and a covering of normal-appearing squamous epithelium, and the stroma is edematous hypercellular or contains scattered high typical stromal cells of stellate type. This is the picture. The fibrovascular core. It is immunoreactive with vimentin, desmine, steroid receptors, and usually not for actin. The post-operative spindle cell nodule, it occurs in few weeks following hysterectomy or other surgical procedures in the region, and it occurs grossly with small friable reddish mass in the vaginal vault. Microscopically, there is ulceration, granulation tissue, and hypercellular spindle cell proliferation, characterized by fascicular pattern of growth, mitotic figures, and red blood cells. Now this is the picture with mitotic figures, and also leiomyomas are the most common benign mesenchymal tumors of the vagina seen in adults and occur in any region of the vagina. And the other tumor-like conditions like aggressive angiomyxoma or angiomyofibroblastoma, leiomyosarcomas, rhabdomyomas present as a polypoid mass and microscopically consist of the haphazardly oriented bundles of spindle to strap shaped cells with cross striations. Commonly they are called the tennis racket shaped cells, and mitotic figures are absent. Now these are the tennis racket shaped cells, you can see, and they positive with the trap staining, or this is the botryoid rhabdomyosarcoma, quite often coming as a polypoid invasive tumor that usually arises from the internal vaginal wall. They occur in 90% of in girls and under the 5 years of age, and grossly it resembles a bunch of grapes. Microscopically, the myxoid stroma in this it contains undifferentiated round or spindle-shaped cells with bright eosinophilic granular cytoplasm, and there is crowding of tumor cells around the blood vessels, and we can see the cytoplasmic protrusions resembling a tennis racket, as I said, with striations, and there is invasive invasion of the overlying epithelium. These are the tennis racket shaped cells. They cause death by penetration into the peritoneal cavity or obstruction of the urinary tract. Usually the treatment is conservative surgery with chemotherapy. The melanocytic tumors are also known as malignant melanomas. They occur in the elderly patients, and grossly the polypoid mass with the blue or black ulcerated areas can be seen. Microscopically, we see the undifferentiated appearance with the amelanotic or ulcerative surface in these, and we find the metastatic tumors which arise from the uterine cervix and endometrium, followed by large bowel, kidney malignant melanoma, and malignant trophoblastic neoplasms. Thank you very much.